I think I will be going to the, any questions on the chat? No. Francesca, very well done. And keep your baby healthy. So I will be going to my talk. Is it okay?
Yeah.
Yes, please.
Okay, so let me share my screen. Share my screen. Share my screen. Okay, so my talk is a little bit about communication and transport of sick babies. You had it mentioned in your case presentation, the frustration of a baby just rushed into your unit without being prepared. And I will try to address some of these points. How can we avoid this? Why doesn't it move? Okay, so every baby that we have in the unit, as it was clear from your presentation too, is coming from somewhere. The information that we gather on the admission has a very big influence on the outcome of the baby. The baby has a maternal history. Baby was followed up by our colleagues in the ObGys, and the history of previous pregnancies or disease of the mother, such as diabetes or blood group for the issue of jaundice, nutritional status of mother, if the mother had any ultrasound examination and we know a priori of some kind of abnormality in the baby, any medication taken by mother during the pregnancy, which might pass the placenta and influence our baby, or any symptoms presented by the baby. This information has to come to us, neonatologists, also about the labor, how the baby was delivered, how was the color of the amniotic fluid, what was the ObGyn, and what resuscitation modalities were used in the delivery room. It sounds very clear, and it's very clear in the admission notes that we developed. In this talk, I want to emphasize how important it is to look at these variables in the light of the presenting symptom of the baby. So if the baby was tachypneic and large for gestational age, then diabetes of the mother is important, because the tachypnea may be just because of hypoglycemia and the symptoms of infant of diabetic mother. So this information has to flow from one side to another. So in caring for a baby, we have a multidisciplinary, multiple team of different sites of wherever the baby is starting, an embryo is starting its life, and up to the time that it's coming to our unit. So communication between the team is really a direct cause of improve the outcome of the baby. If we know more information, we treat properly the possible diagnosis and prevent the complications. So for high-risk babies, the team, a specialized team should be in the delivery room to take the history and the resuscitation itself in the delivery room. But if this is not possible, then information has to flow from one side to another. So many hospitals in many developed countries or many bigger centers develop some kind of risk factors for high-risk labor. which would be a good idea to develop in your centers too, if they do not exist, and make sure that actually the MBU team is attending the delivery in order to do the best possible treatment for the baby in need. So this is a list. It's a list plus minus what we have in our unit. A baby who is preterm, known to have less than 34 weeks gestational age, a certain limit of weight, if the baby is low birth weight, less than 2.3 kilo, meconium state amniotic fluid, fetal distress by monitor, breech presentation, vacuum or any instrumental delivery, or some kind of known congenital anomaly diagnosed by ultrasound, and twins. So this is a list that everybody should know. In the delivery room, they should know. Our colleagues in the ObGyn should know, and they should call us either to the delivery room or to the operating room, so a specialized team is present to take care of the baby. Wherever the baby is born, you need a dedicated personnel to take care of the baby, and the equipment has to be ready at all times. And I put here the issue of equipment because sometimes you want to know who is responsible for the equipment to be there, to be clean, to be already assembled and ready for resuscitation. Sometimes it is the MBU team who at every shift you would go and check that the equipment is prepared and there for the resuscitation. And sometimes it's a midwife or the team from the ObGyn side that is responsible. But this should be a routine check to make sure that after each use, the equipment was put back to a functional status at the delivery room and the resuscitation point. So the communication between the baby, who is the people who care for the baby, is between the OR, operating room, delivery room, and MBU team. This should be clear that you have to know that baby is coming in, and any information has to be communicated to you. If you transfer a baby to other center, you have the same responsibility, that you have to inform the other center that you're sending the baby with this and this and this, and they have to be prepared. And for each time, as you mentioned in Ashura, that you do have this WhatsApp group, you have to have a clear platform to know whom to contact in order to make sure that information flows from one side to the other. Today, we have the phone, the cellular phone, which is a very helpful communication tool. We did have pagers in the past, and of course, the written communication, which I will tell you a few more details later. So it is very important to know, and really to know, that each transport of an infant from one point to another is a risk for complication. If it's only a few minutes or more than an hour or more than a day of transport, it is a risk for complication. And every effort should be made to keep the baby stable at all times. Disrupting care, even for minutes, causes severe complications. And we'll discuss some of these issues as they come. And just to make us think deeply about what is a transport, even putting a baby from the cot to the skin-to-skin position, it is moving, so it is a transport, short transport, but you want to make sure the baby stays stable. The same principle of being stable occurs in all these steps. So moving to the resuscitation area, moving to the MBU, moving to a kangaroo mother care position while on CPAP, moving in a vehicle, transporting the baby in a car or in an ambulance, or even discharging home is some kind of transport. You want to make sure that the baby remains stable, and we'll discuss the different points of being stable. But all this is the thinking procedure of our responsibility as a neonatal team is to make sure that we look at all these points as moving, as transport. So infants are very sensitive for very short periods of instability. Being not fed will cause hypoglycemia. Not receiving oxygen will cause brain damage. And any short period of being not stable is an irreversible damage. Can you please mute yourself? Can you please? Thank you. So continuum of care, infants are sensitive to short periods of instability. Irreversible damage may occur if your baby is unstable, and most causes of this instability are preventable. But when babies are brought to us from other centers, it's called it's called outborns, and inborns are those babies who are born in our centers, and outcome of these babies is different. And it's interesting that in developing countries and developed countries, the data appearing in the literature is a little bit confusing. So, but we know that inborns have usually better outcome, and this is the outcome of an outborn is compromised because it has higher mortality. So if the baby is not born in your center, has usually higher mortality, is higher risk for brain damage, lower ObGyn scores, less antenatal steroids usually, less prenatal care, less cesarean section, and high maternal morbidity. So this is the things that happen to outborns. And the literature shows us the lower graph of each of these graphs shows the lower, the black line shows the survival rate of outborn is much lower than the inborn. This is a graph showing different times in history from 2000, 2009, 2040, and it goes up to 220, the same. Outborns have less good outcome. In a study published from China, which is considered a developing country, they actually show also that the mortality of outborn is much higher than the mortality of the inborns. Interestingly enough, in Kumasi, the work that Dana, Eilon, and the whole Ghana team group did the study, actually we could see that there was no difference in mortality between inborns and outborns. And this is because actually the outborns are different babies in our units. They are not necessarily the sicker ones. They are transformed. Probably the sicker babies are not transferred to our units. So this is one of the explanations showing that actually the data in Kumasi centers is different from what is published in the international literature. So transporting a baby from one point to another is either after birth. The best would be to transport a mom to a center where there is a good MBU, and the baby should be born at that center. After birth, we already have the issues of transport, as we will discuss the complications of not being stable during transport. The uterus of the mom is the best environment in regards of feeding, temperature control, and oxygen delivery. So in the developed countries, many countries where MBUs are not there in small towns or villages, moms are sent to centers where there are MBUs and the baby is delivered in such center. Of course, that transporting in utero is the best to do, but it has a lot of problems because of the distance, because of the cultural and educational beliefs in any benefit from transferring to another hospital, economic problems, financial problems. And there is a lot of parents who will not agree for being transferred to a far away center. And this is a big challenge for you, I know very well. So when you decide about transfer from one point to another, of course, you have to think about, and this is also when you transfer to cut, you will want to think whether the baby can have any benefit from being transferred. And if there is no better treatment in the other center, then you need not to offer or discuss transfer with parents. After you decide that you want to have the transport, you want to discuss with the admitting center and deliver all the necessary data. So they should be ready for this baby to be admitted in their center. Of course, you need the parents' agreement and to think about all the financial constraints and the other complications that would have on the family structure in this situation. Sometimes babies are transferred without mom, and they are arrived to your units before the mom arrives. And this is also an issue that has to be seriously thought about, because you will have to have appropriate feeding and bonding and all the rest of the important points regarding the presence of mom at the referral hospital. So the transport principles, as I said before, the babies should be stable at all times, and stable means temperature control, the prevention of hypoglycemia, prevention of hypoxia, and prevent trauma, to fall or to have any misposition during the transport itself, just by the fact that you rush to a center where you might get better care for your baby. So each time before you transport a baby from one point to another, you will want to think about stabilization, and you have to make sure that you do not, I mean, most of the time that you do not rush with a blue baby from one point to another. Stabilization before moving, and minimize the delay and optimize the care at the point that the baby needs the care. Then you have to make sure that you have all the equipment at the resuscitation area and at trained personnel at all points. And this means at the resuscitation in the delivery room, or accompany a sick baby when transported from one point to another, either from the operating room to the MBU or from the MBU to another hospital. I know that accompanying when you transfer a baby has also challenges, and I would be glad to hear what are you doing today and what are you able to do when you transfer a baby from one center to another. So at each point of stabilization, of course, you do the help the baby breathe principles. You learned about resuscitation, and you also learned that you have to have proper monitoring. So you know your saturation, you know the glucose or bilirubin level or anything that you need to know before you move a baby from one point to another. So proper monitoring also is an issue which is part of the transport equipment, as I would say. So thermal control would mean that you have to have a dry, warm blankets. Skin to skin is the best, because the temperature of mom is always the best temperature control. Even if you have to transport a baby from one point to another and you do not have an ambulance, if it's possible to do skin to skin would be the best way to transport a baby to keep the temperature. But if not, you would need dry and warm blankets, and there are different devices today developed mostly in the cold countries that that assure that the baby is warm during the transport. Oxygenation, you need an oxygen cylinder for transport, and you need a small one when you have to transport the baby from the delivery room to the MBU, or from the MBU to the ambulance, and you need a big one in the ambulance in order to have enough oxygen for the drive, which sometimes can be more than a few minutes. So if you have a longer drive, you need a large oxygen cylinder in the ambulance. And again, I want to remind ourselves that stopping any of these needs of the baby, a hypoxic baby should not be put into an ambulance. It should be stabilized, getting a normal saturation with oxygen, and then put in an ambulance with appropriate monitoring of the saturation and appropriate oxygen delivery during the transport as well. Hypoglycemia, you want to prevent hypoglycemia, and remember, SGA babies can get hypoglycemia very fast because they do not have any reserves. So if the transport from one point to another would be long, you might want to consider an NG tube in order to feed the baby and make sure that the baby does not get hypoglycemic during the period of transport from one point to another. Infant of diabetic mother also needs feeding as soon as possible, again, to prevent hypoglycemia. Reminding you of my previous slide, each of these, hypothermia, hypoxia, or hypoglycemia, cause irreversible damage, irreversible brain damage to a baby, and even for a short time. So it's our responsibility to make sure that this is taken care of during moving the baby from one point to another. In the ambulance of the transport, again, temperature control is a problem. Sometimes it's too hot, sometimes it's too cold, depends on how sophisticated the ambulance is. So again, think about how you make sure that the baby has proper control, a large oxygen cylinder, as I said, safe and secure cot, if it's possible, to make sure that the baby is not moving or getting damaged from some kind of road instability, and make sure that you have some kind of safe transport. And as I said, accompanying on each transport with a trained personnel, it's a recommended thing to be at each transport. So the equipment for transportation would be a warm blanket, oxygen mask, oxygen cylinder of different sizes, as I said, mucus extractor for any possible aspiration. Think about the mode of feeding, an NG tube or IV if it's necessary, a pulse oximeter if it's a long drive and the baby is on oxygen, infusion pump if you have for transport, and also medications and resuscitation equipment in a bag prepared for the person who is accompanying the baby on its way. This is a transport cot that we have in our unit, and I remember when we visited, we have to have this at our center in order to move babies from the delivery room or from the operating room. This is a small oxygen cylinder, and it has here, it's not pipe. We don't have all the tubing, but the baby can have the oxygen needed for the transport. So the communication, as I said, from one point to another between the ObGyn team and the neonatal team, it's very important, and we can do it by phone, and we have to also make sure that we do it by notes, clear at each point. Midwives should document resuscitation and stabilization and vital signs before you transfer a baby to another center. Make sure that the baby has its vital signs documented so we know how we started and we can know how it gets there. Was the temperature normal on the beginning of the road and was also normal at the admission, or did we anything that we have to learn even from these transport issues? laboratory data have to be documented, so we know what was checked in one site, and this is communicated clearly with the other side that admits the baby. So the timeline, I just put it here. I know it's not always like this, but resuscitation at the delivery room should take 30 minutes or plus minus, and then come to a stable stabilization of the baby and transport it to the MBU with the appropriate equipment that should be ready at the delivery room. And then if needed, the baby transported to another center, again with the best stabilization, thinking, and equipment that is necessary, as I just pointed out in the previous slides.
Bye.
So in conclusion, just a second. So we have to be able to identify all points of transport. And as I said, if you take a time, you can identify which of all the movement of the baby from one point to another is actually should be considered as transport. Be prepared with equipment at all points, so you don't get caught in a place without an embu bag if the baby might need it on its way, and make sure that you have an also prepared well-trained personnel at each point. Keep baby stable at each point and establish a good, clear communication which in between the teams. So these are the main points that I wanted to discuss, trying to cover the relationship that you must develop with the ObG team. It took us 15 years, and Professor Karplus remembers the beginning of our journey to make the ObG team a partner in the care of the babies after being delivered, and not only before they are delivered, and then take our responsibility in making sure that the baby is stable all the way until he gets home. So this was my talk, and I'm ready, prepared for questions. Okay, I hope I wasn't too fast or too not clear. I'm prepared for questions.
Aggie, thank you very much. I mean, you covered really very important points, and even they relate even to the case that we just that was just presented. I want to read loud also what Alberta wrote to everybody in the chat, and it's another issue that if you remember, when first we arrived to Kumasi, transports were done by taxi drivers, and this is what Alberta is writing. Sometimes the parents are unable to afford the services of an ambulance, so they go in private car or taxi. It's quite risky for a staff to accompany them. Recently, we had an incident when a nurse accompanied the patient in a taxi. The parents instructed the drivers to take them to a herbalist instead of cat. It only took the resilience of the nurse to get them to go to cat. Some of these patients are not trustworthy. I really feel uncomfortable to accompany a patient in a taxi or a private car. It's Alberta, what you wrote is eye-opening. We know that when you have an ambulance and when you have a good transport, everything is very easy. And communication is extremely important. Paper communication between centers, when you send a baby to another center, to write a few words about what happened is extremely important. And I think that Fred said something on this, that they didn't know what happened in the other hospital. And if you happen to go in a taxi, which we absolutely understand that you're uncomfortable, I didn't know that parents had to pay for the ambulance. I thought it was still free for everybody, but you have your phone to connect with the doctor who sent you and to get advice. And I can only applaud this nurse that managed to redirect the taxi or this private car to Kat for the baby, to save the, hopefully she saved also the baby.
Yeah, so with the ambulance, officially it's supposed to be free, but unfortunately they sometimes ask for money, but officially it should be free.
I want to kind of there are many black boxes that I don't see the faces, but when we give these talks, we want to learn and understand the gaps and the things that are unacceptable in the care of babies and work around these issues. And I absolutely understand the frustrations and the challenges and the obstacles and financial issues, and the thing that the only person who is fighting for the health of the babies is you guys. I would love to see your faces, because it's only you who really Benil. Okay.
Do your work, Benil.
So thank you. So we have we don't feel like wanting to criticize anything or anything that is just to point out that this is what should be done for a safe transport or communication, and work around it, and each time add a little bit more. I must say that a few years ago, 15 years ago, there were no ambulances. And now there are ambulances, but they shouldn't take money. So let's make sure they don't take money. It's very, very, very frustrating. And thank you, Alberta, for sharing with us, just to put us in the right perspective about what needs to be done. Any clarification about what I said? Any more questions on the chat? I didn't have time to read.
No.
Okay. Okay, I hope when I will be there, you will have we'll have opportunity to discuss. I'm going to be doing rounds in both centers, at least twice in each center. I would like to come in the evening also, to help to meet also nurses who come in the afternoon shifts, and have the opportunity to raise questions and discuss anything that went through these 3 months. So Elon, closing remarks before I close it?
First, I think that it was a good, was a good way to finish all these sessions. Again, I'm really happy that it's possible to go to Ghana. I'm sure that Ashura and Rita, please tell your medical superintendent or the manager of the hospital that a visit is coming, and please, we should get some time that Agi will be able to talk with the hospital management. It's important. It's also important for you.
Yes.
Please prepare questions for Agi. Use Liraz. I think she's off by now, but I know she's still here. Really, it's a blessing that she's coming over there. Show her your beautiful country. we are deeply in love with Ghana, so please show her your beautiful country. And we hope that we will have more sessions and more live sessions.
Yeah.
Okay, thank you.
Yeah,
Elo.
Aggie, thank you so much. I think your presentation was very good. I was just wondering, I don't know if we could organize another Zoom just for this session, not for Kumasi South and Suntreso alone, but the link to be shared to other facilities around in Ashanti region. Is it okay with you?
No problem.
Yeah,
of
thank
course. Listen, Benil is sending the YouTube links to all the sessions.
Okay.
Feel comfortable to share it with whoever you think it can use it. Really, it's for everybody. It's not, it's for everybody who have time to listen. And if you think that a session like this if you want to, to assemble people, because people, I know we're lazy, we don't want to hear more lectures, but if you're able to organize a session like this, and Aggie will be happy to talk about transport, even when she comes to Ghana, I think she may you may do it over there.
Okay.
This 3 months of intense meetings, I would say, we called it a workshop. It put 40-something people all together to discuss issues. The plan will be, after my visit, that if you will find this useful, we want to continue and having monthly meetings, just case presentations. You have I sent you the
template.
The template, and just present cases, and we have opportunity to discuss gaps and how can we close gaps and how can we plan quality improvement projects. And so the plan is that we continue meeting once a month, 1 hour, not 2 hours, and continue the case presentations. So we are not done.
Yes.
15 years we are working together, and we will continue this joint effort. So I want to close this meeting today by saying thank you to Benil and to Winty and to Elon and to Professor Karplus and to Justin and all the Ashura and Rita and the Ghana partners who presented. I hope I didn't forget anybody. And hope to see you in person, get to know you and discuss live. And the next meeting case presentation will be sent out to you on the same communication that we established between us, and we will invite you to a case presentation somewhere in April. So good night, everybody.
Yeah, so thank you very much. We too, on behalf of Kumasi South and Suntreso, we'd like to say a big thank you, because in these 3 months, we have learned a lot of things. We have been able to discuss our issues, and we know that this is not the end. We are going to continue with the sessions. We are going to continue with our communication, and we can't say much, but just thank you very much, and God bless you.
Thank you. Good night, everybody. Bye-bye. See you in 1 week.